role of PCI in stable coronary disease, and the question was, is it useful? Well, as we know that prior studies, notably Courage and 2D, did not show that revascularization in stable patients with coronary disease prevents death or MI. But with these trials were done a long time ago. They enrolled patients offering angiography, so naturally low-risk patients were enrolled. They excluded patients with high anatomical risks. And most patients had minimal or only moderate ischemia. And also, they did not use contemporary stents, what we're using now. Physiologic guidance like FFR, using surgery, bilateral memory arteries, and pharmacotherapy. But also, as we all know, that symptomatic relief is the primary goal of PCI in stable patients and is known around the globe. But I'm going to give you a very provocative trial. I'm sure you heard about Orbita trial, which was a double-blind, randomized controlled trial between PCI and no PCI using the sham procedure. In fact, patients were taken into the cath lab, and they did not know whether they will receive PCI or no PCI. But let me, and they say, devil is in the details. This was a trial. They enrolled 200 patients over a 4-year period, and they gave them first medical therapy. After giving medical therapy, after 6 weeks, patients had angina class 1 or class 2 in 62%, and there was no ischemia in 30%. And the duration of follow was just 6 weeks. So it was a major trial in Lancet and a lot of hype about this. What the primary outcome was change in exercise time. As you see here in sham versus PCI, it was not significant. P-value was 0.200. But if you look just for 6 weeks, although unless the trial was longer, that tells you the power of the trial. But looking to this graph, the exercise time was almost double with PCI than sham procedure. But they looked to other secondary outcome. Change in Seattle Angina Questionnaire, change in the angina frequency, change in treadmill score, again, does not look significant, but there's a trend. I'm sure if this trial was longer than 6 weeks and had a larger number of patients, we would have answered this question. But it did look into the peak stress wall motion with dobutamine stress echoes. It was very favorable with PCI than sham procedure. But let me tell you, all the interventions around the globe were almost shocked with the editorial in Lancet in 2018. It said, quote, last nail in the coffin for PCI and stable angina. And they made some very disturbing conclusion of this small trial by the editorial board, but let me answer one by one. First thing they said, that this trial, again, 200 patients, 6 weeks follow-up, 30% had no ischemia. What they concluded, quote, this trial shows unequivocally that there are no benefits for PCI compared with medical therapy for stable angina, even when angina is refractory medical therapy. Again, that's not correct. Then they said healthcare providers should focus their attention on treating patients with stable coronary disease with optimal medical therapy, which is very effective. Again, not correct. And then they wanted ACC, AHA to change the guidelines and downgrade the recommendation of PCI in patients with angina despite use of medical therapy. I think with this negative editorial, I'm sure even in India, around the globe, there was this media reaction to Orbita trial. which was very extensive and vigorous, though mostly one-sided and largely following the negative tone set by the editorial. What is interesting is, from this trial, when the trial was over, the principal investigator was in the Sky meeting a year later. You know what he said? 85% of the patients who were in the sham arm had PCI when the trial was ended. In fact, then there was, from the same group, they looked to these patients who had abnormal FFR. There was a remarkable reduction in FFR post-PCI, which was in line with the improvement in stress echocardiography, and also freedom from angina was better with PCI than sham. Now, because of this Orbiter trial, where the therapeutic benefit of PCI have been challenged in patients with stable coronary disease, and also Orbiter said that PCI has a placebo effect. I'm going to share with this very important trial where they examined the impact of PCI on exercise response in the cath lab regarding coronary circulation, microcirculation, and systemic hemodynamic in patients with stable coronary disease. So what they did, they took 21 patients with critical single vessel disease in the cath lab using exercise protocol in the cath lab using spine ergometer, and they looked into the functional parameters, systemic circulation, coronary circulation by IFR, FFR, as well as microcirculation. What they found was that when you do PCI in these critical cases, and you do exercise in the cath lab, and it can show you here, they had a high lactate level. It was a good exercise in the cath lab. There was a remarkable reduction in the angina, dyspnea, post-PCI in the cath lab. Also, the exercise time was increased with PCI. Again, totally opposite Orbiter trial. Also, the most important thing from this trial, we found, and it was shown, that coronary flow velocity increases after PCI. Systemic resistance reduces after PCI, even with exercise. The pressure gradient reduces after exercise, as well as without exercise post-PCI. The pressure ratio increases with PCI. The distal coronary pressure increases after PCI. And the diastolic microvascular resistance is improved by PCI, even with exercise. So the conclusion of this trial was that examining solely objective physiologic measures during physical exercise, PCI for single vessel coronary disease shows clear evidence of meeting all that could be demanded for therapy for ischemia. So again, unequivocally, PCI does not give you a placebo effect. So then came the FAME2 trial. As you know, it's a very important trial because they had to stop the trial prematurely. It was terminated because there were too many people coming with urgent PCI in the medical arm. So what they did here, they did the patients had FFR. Patients with FFR of 0.8 or below were randomized to PCI plus optimal medical therapy or optimal medical therapy. And the ones who has FFR of more than 80 were put in the registry. The primary goal was death, myocardial infarction, and urgent revascularization. Look at here. Trial was terminated earlier because the patient was coming for urgent PCI in the medical arm. Look at the difference between the PCI and medical therapy. a 9-10 day difference. But it also shows you this trial that if your FFR is greater than 0.80, you don't have to do nothing. They do very well. Now we have published 5-year data on these patients, the FAME2. Again, at 5 years, it continued to show improvement in death, MI, and urgent revascularization. But we know none of the trials have shown, whether it's bypass surgery, that we improve the death aspect, except in certain subsets like left main disease. But there's a trend towards the latter part, we may be preventing myocardial infarction. In fact, if you look to the recent publication last week in Circulation, they look to the people with ischemia trial. Towards the end, there was a trend of prevention of MI with revascularization. But what is most important is the urgent revascularization, a remarkable reduction with PCI as compared to medical therapy. So really, in conclusion of this FAME trial, showed that when the FFR is greater than 80, outcome is favorable with medical therapy. But the FFR is less than 80 or 0.80, or you can do IFR, which is 0.89. PCI with current drug-eluting stent shows sustained benefit for preventing urgent revascularization, and the rate of spontaneous myocardial infarction is reduced, especially when you do longer follow-up. There's unequivocally symptomatic relief and without late catch-up phenomena. So really, I like to conclude that when Dr. Mahaputra sent me an email, he said, would you like to talk on role of PCI in stable CAD? Is it useful? My answer is yes, it is useful, of course, in selected patients. But let me tell you, ladies and gentlemen and my friends, yes, you can take a lot of pills. You have to make sure the patients are taking pills. Versus the quality of life. I think what matters is the patient's preference. You have to ask the patient. Thank you very much for your kind attention.